introduced for the Henry Baylis lecture by my mentor, Goldberg, is an accolade that I never thought would happen. And really to all of you in the crowd who have been mentors, colleagues, friends throughout my journey, from the bottom of my heart, I wish to thank you. I think it's probably true that most people know the name Henry Baylis, but they don't actually really know exactly what he did for the specialty.
His contribution to that DNA can be summarized in three concepts. First of all is creativity. Second is boldness. And the third is collegiality.
I remember that in F.A.C.S, there was always this a little bit of tension going on with essentially the direction of F.A.C.S.
The world of aesthetics, in particular, Henry was an absolute pioneer, and we all benefited. The entire specialty has benefited.
Henry was known for his cosmetic surgery skills. The founder and editor of the Green Journal. Before it was green, it was a purple journal. Henry, from this role, took it upon himself to push the specialty forward and curate what we were thinking about in the 1980s.
Cutting a husopulsing eyelid pedicle flap at 2 weeks versus 4 weeks. A structural approach to cicatricial and tropion. The development of a Pyrex lid plate for transconjunctival surgery. Transconjunctival lower blepharoplasty. Transcaruncular approach to the medial wall. Facelifting surgery. Brow lifting surgery. Coronal forehead lifting surgery. Working with Norman Shore on the structural approach to thyroid decompression, the 4 stages of thyroid decompression surgery, eyelid reconstruction. Almost every area of oculoplastic surgery has been influenced by
Transconjunctival surgery, I think, really pivoted cosmetic surgery, at least in facial plastic surgery. That's the state of the art now.
Again, it wasn't just cosmetic surgery. He also pushed the specialty forward in orbital surgery.
Presented his first 20 cases of orbital decompression. Crowell Beard, one of his mentors, stood up at the end of the lecture and said, "Dr. Baylis, that's malpractice for an ophthalmologist to do orbital decompression."
That Henry Baylis was a bold innovator. He brought us techniques, transcaruncular approach, conjunctival surgery, orbital decompressions, facelifting surgery in the 1990s. And it's really more than that. He brought a mindset and a way of thinking.
He just had such a novel approach to things. He never felt limited by what was in a textbook. He'd sort of come into every surgery and feel like he was free to invent something new.
He would look at a situation as an incredible problem solver and would intuitively figure things out in the most linear and zen-like, simple way possible.
Our specialty is what it is in 2024 because of the legacy of Henry Baylis. And I wanted to use this podium as an opportunity to remind us all of what that legacy is. Baylis's approach, it was this beautiful marriage of science and intuitive creativity that he brought to the table. And the first question to ask is, does creativity even belong in the field of surgery? Creativity can be unpredictable. It can lead to morbidity and complications in the operating room, and we should just stick to the standard of care. I think Henry Baylis would have said, well, that's not how I operate. In the world of oculofacial plastic surgery, we're not just pigeonholed ophthalmologists. We have this wide, multiple specialty approach to how we perceive medical and surgical problems. And as oculofacial plastic surgeons, we operate for function, of course, but also for form. Let's now talk about the science of creativity in more detail. Those of you who took neuroscience classes in college may remember that Roger Sperry received the Nobel Prize in the 1960s for the famous corpus callosum split brain study. The right side of the brain is responsible for unconscious, nonverbal thinking, a lot of perceptual and intuitive thinking that allows us to unlock our subconscious approaches to process. If we live in this right side of our brain more, we can actually achieve. He was finding himself in this flow state. When we are dealt with high challenge levels, we can become anxious and not be able to achieve the appropriate goals of the task. But if we have a high skill set and we're utilizing the full resources of both cerebral hemispheres, we find ourselves in this beautiful state of flow where we're achieving high output using a high skill set. And later on in life, Einstein reflected back on his own work and said to us all, I didn't really have a better brain, I just learned how to harness it and use it better. There is science on creativity in surgery, and Einstein tells us that you can perform thought experiments before you're in a situation more. He would tell us to define the problem, and then using your own experience, analyze that particular problem and try to find a solution that tackles what the core aspect is of the problem. Then in your mind, test the result, and as you're testing that result, observe your internal observations and try to explain what you're seeing so you can hone this idea further before you bring it into the real world. If that process sounds familiar, it's certainly something that we as surgeons do all the time. For example, in Mohs surgery, when you're presented with a defect, and in your mind you have to visualize various patterns and quickly make decisions before you cut on somebody's face. And so this is surgical innovation in real time. Insights and wisdom in utilizing that experience. Innovative surgeons also comfortable with improvisation. The innovative surgeon has sincere observational skills. The innovative surgeon recognizes serendipity when it happens and exploits that opportunity. And then maybe most importantly, they question the status quo with some directness. In my career, I've tried to channel this creativity that I inherited from the Baylis and Goldberg legacies. Two general categories I'd like to cover for the rest of the talk: structural mobilization and volume recycling. Structural mobilization, if we can respect the layers of the face, you can then be creative. The layers are the skin and the subcutaneous layer. There's the layer of the SMATs, retaining spaces and ligaments, and the subperiosteal plane. The frontotemporal ligament, the periorbital ligaments, which include the orbicularis retaining ligament, as well as the superior orbital retaining ligament, and then the midfacial ligaments, the zygomatic ligament and the masseteric ligament. Structural mobilization is, with appropriate ligament release and accurate layer dissection, we can achieve safe and dramatic mobilization in surgery. So with an endoscopic upper facelift, this is more than just a forehead lift. We're talking about lifting the upper face, the temple, and the cheeks. And this can be achieved with a complete ligamentous release in the subperiosteal plane, showing here lateral brow, medial zygoma, masseteric, and inferior orbital retaining ligament release. And then we're using a Trepsat elevator to stretch the ligaments off that bony face, and we're deep to the facial nerve, so it's safe to be relatively assertive with perpendicular vectors. And once we've got this full release, a single vitral suture placed in the temple will lift the entire face. Another example is in deep plane facelifting and deep neck lifting. We can achieve relatively dramatic structural movements by recognizing ligamentous release opportunities and plane manipulation. So in facelifting, we release, in this case, the zygomatic cutaneous ligament, the parotid attachments, the attachments of the platysma, to be able to achieve dramatic mobilization, and then relatively simple sutures can lift the entire face. This is a concept that Karen Brown and I presented at a recent spring meeting, which is the suspended orbicularis brow lift. This is a technique where we can take a clean, simple subcutaneous plane from a temporal incision, extended dissection down using transillumination to the orbital rim and exposing the orbicularis from the superficial plane. So we're flying above the facial nerve in this situation. And once you get to the orbicularis with a relatively quick dissection, we can mobilize that SMAS, the orbicularis, by lifting it, and simple mattress sutures can suspend this orbicularis up onto the superficial fascia, lateral to the frontal muscle, and these sutures are placed in such a way that they avoid penetrating into the frontal branch of the facial nerve by being cephalac to the nerve trajectory. And this produces an elegant restructuring of the lateral brow in conjunction with blepharoplasty under local anesthesia. This has become a workhorse in our office. And the final structural mobilization concept I wanted to share with you is something we presented at ASOPers many years ago, which is that we can actually modify bone structure in the face to be able to mobilize soft tissue for purposes of reconstruction. So here's the alpha patient who had a melanoma removed using a slow-Mohs technique. And in the preoperative area, when I was undergoing that process of trying to figure out how to close this defect, I noticed that she had a dorsal hump. And we know from rhinoplasty surgery that we can remove the dorsal hump. And in patients who are relatively older, over 50, when you remove the dorsal hump, there's actually excess skin that has to be redistributed. So in this patient, we manipulated that opportunity and created a flap that extended onto the nose in a subsmass plane and removed cartilage and bone to be able to create deprojection of the nasal structure. And this allowed the nasal flap to mobilize over and take care of almost a third of the defect. The patient was super pleased with her outcome and loved her new nose as well. And so this has become an opportunity that we utilize in the operating room. And I think it's a nice example of how bone structural mobilization can actually affect soft tissue manipulation as well. So let's talk about the second category of creative maneuvers that we can utilize in the operating room, volume recycling. And so from my perspective, historically, the world of plastic surgery and oculoplastics would resect tissue and throw it away. From my standpoint, why should we throw away good fat and tissue when we can recycle it for the same purposes of the outcome of the surgery? For example, transposition lower blepharoplasty is a great way to repurpose orbital fat that should be removed for cosmetic reasons, and we use it to augment the midface. What about upper blepharoplasty fat? Most of us simply cut it out and it ends up in an incinerator. Rather than throwing it away, the upper blepharoplastic fat could be reutilized for cosmetic and reconstructive options in the periorbital region. So one example is the transposition upper blepharoplasty, where we can actually dissect in a subbrow dissection, pre-periosteal release of the superior orbital retaining ligaments, and then mobilize a preoperative fat pedicle and place this up under the brow. This addresses upper orbital volume excess, fills the brow, and produces an elegant periorbital rejuvenation that's beyond just that simple blepharoplasty incision. Fat recontouring of the upper orbital fat is a tool that I think is a really wonderful opportunity in cases where we want to mobilize and maneuver volume. We can merge the fat particles together and precisely adjust exactly and titrate where we want that volume to be for this particular patient and this particular site. We can place the fat in a subbrow space. We can dissect under the orbicularis and create subbrow augmentation for Asian blepharoplasty. We can also telescope out the medial fat pad and utilize it in areas that are even beyond the eyelid. For example, another Karen Brown surgery we presented is corrugator resection, but resecting the corrugator to lift the medial brow oftentimes leaves a deficit of volume. So in this situation, we can actually telescope out the medial fat pedicle and bring it under the subbrow space to fill that volume and mobilize orbital fat for a different purpose. Another option is recycling free fat into the glabella. And I'm not talking about fat injections from abdominal fat, but I'm talking about creating an actual radix augmentation during a brow lift and blepharoplasty. So again, rather than throwing away blepharoplasty fat, we can mince it with a little bit of saline and place this fat into a spigot that we can visualize an endoscopic approach to the radix and deposit the fat and manipulate the fat and place it into the nasal frontal junction to create a beautiful augmentation. And because it's such a vascular area, this fat lives very well and enhances the outcome of a brow lift and blepharoplasty. We can also use the same concept in the cheeks. So we can place this minced fat into a 3 cc syringe, and using a 14 gauge catheter, we can augment the midface for patients who have a negative vector or an asymmetry and make their blepharoplasty go from a B+ to an A+. And here's someone who had a flat midface who benefited from this free fat grafting procedure. Now, beyond fat, we can also utilize SMAX for the same purposes. We can use SMAX as a lower eyelid reconstruction tool. This is Goldberg's end-glove lysis approach. And this is placing SMAX into that pocket and securing it with full-thickness quilting sutures to achieve volume augmentation. We can also use SMAX along the orbital rim. And so here's a patient with a negative vector who needed a complex ectropion repair. And by fixing the negative vector and placing SMAX and augmenting the volume, we could achieve better results than if we had not addressed the periorbital structures as well. SMAS can be used as a genioplasty alternative. It can be used as a lip graft alternative. And because SMAS has a structurally more rigid, fibrous nature, in my opinion, in locations like this, it does much better than autologous fat grafting from the abdomen. And here's a patient a year out from a SMAS lip augmentation. And the final example I'll show you in this category of recycled volume is using a buccal fat pedicle for orbital-facial reconstruction. So this is a patient who underwent a surgical repair for trauma and had a poor outcome, devascularized tissue. These are tough cases when there's no blood supply in the eyelid. Whatever you're going to do is destined to fail. So you can utilize a vascularized buccal fat pedicle taken from an oral incision, fed up in a subperiosteal plane, and placed right at the orbital rim. And this fat lives because it's bringing along its own blood supply. So, closing thoughts. I just wanted to throw up a vintage photograph from 2007. Top left, this is me as a senior fellow standing next to a young great doctor. She looks the same, sitting here in the front row. Right below me is John Honig, who ironically was giving the Baylis lecture that year. We're all proudly taking a photograph around Henry Baylis and just enjoying that moment all together. Now, Henry Baylis is not just part of the UCLA legacy. He's part of the entire oculofacial plastic surgery legacy. He brought creativity, innovative approach, open-mindedness that hopefully I've been able to showcase for you today. If we find ourselves in the flow state more often, we're more likely to be able to channel our intuitive powers to solve problems that we don't even realize that we can have an answer to, so we can inspire ourselves and the next generation.